Hello everyone. We recently had World Asthma Day where we discussed threadbare the extent of problem. Today I am going to discuss with you a particular type of phenotype of asthma that is called allergic bronchopulmonary aspergillosis. Is it an uncommon disease or it's a misdiagnosis? And over a period of next 20 or 25 minutes, I'll be impressing upon you as to it's not uncommon, but usually it is a misdiagnosis which leads to catastrophe for the patients. With the advances in medicine and the diagnostic facilities, it is possible to diagnose allergic bronchopulmonary aspergillosis, which I'll be reciting as ABPA early and manage it so that patients lead a normal life. Talking about the global burden of asthma, this was a study that is what is known as Global Asthma Network, which included 101,000 children in 44 countries and 16 countries, and which showed that 9.1% of children have asthma, 11% of adolescents, and 6.6% of adults have asthma. So in 2019, there were 262 million people affected with asthma all over the globe. Amongst the India, there are 35 million people who suffer from asthma. And unfortunately, fewer than 30% of people with current Bs, the diagnosis of asthma was confirmed by a physician. Further, even in these diagnosed patients, the inhaled corticosteroid was used by less than 10% of patients. And more than 25% of patients are hospitalized at least once in a year, probably due to inadequate treatment. Isn't it worrying? Nobody should think that asthma doesn't kill. All over the world, annually 250,000 people die of asthma, and 80% of deaths are in the developing countries, and two of the three deaths are actually preventable. So, what do we desire when we manage asthma? We desire a control so that person achieves highest standard of success, be it in the education, be it in the sports, be it in all spheres of life. Like this Mr. Kashyap, who was a gold medalist in badminton, or Christie, who was an ice skater, or bandit like Beckham, we all know, famous footballer, Alan Border, the famous cricketer, and this Kolkata boy who defeats asthma and scaled 9 peaks in 5 years. So, coming back to the point, ABPA, allergic bronchopulmonary aspergillosis, is it uncommon disease or a misdiagnosis? So I start with the case. This is a 24 years old girl, an advocate, who in the year 2020 presented to a center with history of asthma since childhood, with also family history of asthma. And she had cough, she had hemoptysis, she had breathlessness, and her sputum for AFB was negative. Probably since she had hemoptysis, she was investigated and a CT scan was done. And this is her CT scan where you can see abnormalities. And if we could enlarge it, there are nodules, there are bronchial wall thickening that you can see, and there is bronchiectasis. Now, this patient in the year 2020 received antitubercular treatment for 1 year, as it usually happens in India. In 2022, again she received ATT for 1 month, but there was no response. Then received antibiotics for 1 month without any response. She presented to our center in September 2023 with fever for 1 week, which was in July, cough with expectoration for 3 months, and shortness of breath for 1 month, and wheezing for 1 month. So on examination, she was comfortably sitting, and there were bilateral bronchi. So when we did a CT, it was a horror to us that as compared to 2020 CT, quite a bit of lung was destroyed. There was cystic lesions, cavities formed, there was evidence of fibrosis. Besides that, there were a lot of nodules which were there. There was hair trapping also. And this is the enlarged view. You can see this blank area, which is actually because of the traction, there is a formation of cysts, and there are some nodules also. When we did our PFT, as expected, there was a restrictive changes, but there was a significant change in the bronchodilator reversibility with the nebulization of salbutamol to the tune of 15%. So we further evaluated this patient. We did blood investigation. Hemoglobin was 11.4 grams. The TLC was 16,700. Platelets were normal. Absolute eosinophil count was 1,510 per cubic milliliter. The IgE was more than 5,000. The lab was not reporting beyond that. And that was staggering. When we did Aspergillus specific IgE, it was 69.2 Ku per liter against a normal of 0.1 to 0.35. Sputum for smear and gene expert was negative for acid bacilli. So the diagnosis was asthma with allergic bronchopulmonary aspergillosis, clearly a misdiagnosis. So how common is ABPA? Prevalence of ABPA in patients referred to secondary care center is 0.7 to 3.5%. This is from Dr. Ritesh Agarwal, who has done maximum work. And if you take from a tertiary care center like PGI or AIMS or another big hospital, the prevalence of ABPA ranges from 2 to 32% with a pooled prevalence of 13%. So if you see at a tertiary care center, 100 patients of severe asthma, 13% are likely to have ABPA. However, allergic sensitization to Aspergillus fumigatus is seen in 6.4% asthmatics in general. And global burden is 4.8 million, and ABPA complicates on an average 2.5% of asthmatics. And in India, it is estimated that there are 1.4 million ABPA out of 28 million asthmatics. The question is, are we diagnosing them? So how does ABPA occur? What is the pathophysiology? It is actually result from exaggerated Th2 type immune response to Aspergillus antigen. In United States, a study was conducted where they found that an average human being inhales 100 conodia of Aspergillus every day. So Aspergillus is a ubiquitous fungus. Now, susceptible individuals mount an exaggerated Th2 mediated immune response, leading to production of Ig antibodies against Aspergillus antigens. And this immune cascade causes chronic airway inflammation, bronchial hyperresponsiveness, eosinophilic infiltration, and airway remodeling, which leads to mucus plugs. The accumulation of mucus plugs and fungal hyphae in the airway is a hallmark of ABPA. Now, if you look at the histology, this is a gross specimen of a patient with aspergillus. There is a dilated bronchi filled with mucus. This is eosinophilic mucus. This is an eosinophilic mucin where you can see the aspergillus hyphae. And this is also around, around the bronchi, there's a eosinophilic mucin which is seen. And this is another stain where you can see portions of the aspergillus hyphae. This is charcoal laden uh, crystal which is seen in the eosinophilic mucin, and this is eosinophilic inflammation. So this is the histopathology of ABPA. So what is the clinical presentation? Why it is missed? It presents like asthma, but usually it occurs in the third decade. But in our experience, it can be diagnosed at, we have seen patients first time at the age of 70 and 75 years. It presents as asthma, at times a thick brown sputum, which is actually, in my experience, is not so common. So don't think that there is no brown sputum that cannot be ABPA. Quite often it is unrecognized for years. Systemic effects, some patients may experience weight loss, fever, and fatigue. In the late stages, there are signs of pulmonary hypertension, cor pulmonale, and respiratory failure may occur. And hemoptysis is an uncommon feature as seen in this patient because there is bronchiectasis, so hemoptysis can occur. Now, when you investigate such patients, if the eosinophil counts are 500 per cubic milliliter, there is a 70% chance that this patient may have ABPA. However, if the IgE is more than 500 internal units per ml, then specificity is 70%. The most important test is Aspergillus specific IgE. If it is more than 0.35, there's a sensitivity is 99 to 100%. So with that, this becomes a test which is a screening test for ABP and patients with asthma and raise specific IgE to Aspergillus more than 27 milligram per liter. So serum IgE is not so useful for the diagnosis where the specific Ig is more useful, but serum Ig is most useful for monitoring the response to therapy. When you do lung function tests, there's a airway obstruction, there's bronchial hyperresponsiveness and gas exchange abnormalities as you would see in asthma. This is a valuable for guiding the treatment. And fixed airway obstruction and reduced lung volume can be found in progressive disease as we saw as the fibrosis and bronchiectasis sets in. And there are newer diagnostic tests which are now available. They are concurrently commercially available recombinant Aspergillus fumigatus antigen, including F1, F2, F3, F4, and F6 are available. They are thought to be highly specific, but not too many studies are there. There are also a carcinoembryonic antigen and periostin. They are not so useful in the diagnosis of APP. Now, the radiology is very important, but I will come to it that we should not wait for radiological abnormalities to occur. The classical finding in the radiology is central bronchiectasis, which is hallmark of ABPA, and it refers to the dilatation and thickening of the bronchial walls in the central airways, predominantly involving larger bronchi. As you see in the CT scan, bronchiectasis, which is largely proximal. It's not that periphery is normal. You can see the bronchial dilatation, bronchiectasis in periphery. You can see centrilobular nodules also. You can see bronchiectasis here also. So there is mucoid impaction. There is accumulation of thick tenacious mucus within the dilated bronchi seen in ABPA. There is obstruction of bronchial lumens and lead to distal atelectasis or areas of consolidation There's visualization as bronchial opacity or finger and glove opacity, also called as high attenuated mucus on radiological imaging. You can see this bronchus filled with mucus, and this is one of our case which actually looked like a collapse of the lung. And when we actually did the uh, bronchoscopy, as I will say, we diagnosed it as fungal infection. There could be peribronchial infiltrates, there could be patchy nodular surrounding the bronchi. The infiltrates are often associated with areas of bronchial thickening. Now, this is classical finger and glove appearance. As if you see this kind of CT, this is the bronchus which is dilated, not filled with mucus. These are the bronchi which are filled with mucus. And of course, there are other features also. You can see a lot of central random nodules that you can see here. Now, there is a fibrosis and scarring. There is linear opacity with traction bronchiectasis with architectural distortion, as you saw in our case, which we are presenting. Now, if you see this particular CT of person with ABPA, you can see there is a bronchiectasis in the distally also, and there are several nodules that you can see. So, it's not that you have to wait for high attenuation mucus or finger and glove appearance. There has to be a high index of suspicion. This is a 45 years old male from Bihar who had an X-ray chest like this. He had respiratory symptoms. He was a non-smoker. We thought we are dealing with probably CA. You can see a mass like. And then when we did a CT scan, similar picture, there was sort of a atelectasis, there's a collapse you can see here, but there's heterogeneity inside. Now, when we did the bronchoscopy, one of the segment of the upper lobe was completely blocked, and we were able to suck out this. This is being mucus being sucked, and we were able to clear it completely. And on investigation, he was diagnosed with bronchoscopy. Now, bronchoscopy is not routinely indicated. It's particularly indicated when there is diagnostic uncertainty, like you saw in this previous case, where there is a evidence of bronchial obstruction. Now, when you do bronchoscopy, the sample should go for cytological analysis, including identification of Aspergillus species, eosinophil count, and fungal culture. Now, how high attenuation mucus? You can see this and with this arrow. This is pathognomonic of ABPA. And this is another picture of finger and glove appearance with large bronchial dilatation. Some are filled and it becomes like this. When they are not filled, they are empty. So this particular unfortunate girl, an advocate, so we diagnose it as allergic bronchopulmonary aspergillosis, that is ABPA. So the diagnosis of ABPA is a combination of clinical, immunologic, and thoracic imaging finding. The International Society of Human Animal Mycology has proposed recommendation for diagnosis of ABPA. The initial diagnostic criteria were given in 2013, after which it was modified. The modified criteria, ISHAM criteria, are the patient with asthma, with Aspergillus specific IgE of 0.35 or more, with serum total IgE of more than 500 international unit, and at least two of the following. As that is Aspergillus fumigates specific IgG of more than 27 milligram per liter, bronchiectasis on CT, and peripheral blood eosinophilia more than 500. If you should have two of them. Now, the clinical 7 stages have been described, but not all patients undergo those stages. So, in day-to-day practice, they are not so useful. Now, coming to the management, how do we manage ABPA? Because ABPA is a tendency, so we don't like to say treatment, it is a management. So, corticosteroids are the mainstay of treatment of ABPA. We know that asthma, we give corticosteroid only in the emergency situation, in a very rare situation, and we avoid it. But the treatment of ABPA starts with corticosteroids, and there are two regimens which have been suggested. The medium dose regimen is 0.5 milligram per kilogram body weight of prednisolone given for 1 to 2 weeks, then alternate day therapy for 6 to 8 weeks, and finally tapering to 5 to 10 milligram every 2 weeks until stopping it after 3 to 5 months. The high dose is consisted of prednisolone 0.75 milligram per kilogram per day for 6 weeks, followed by zero point 0.5 milligram for another 6 weeks. But I personally prefer the medium dose because there is no difference in the outcome. So, the treatment goals are controlling pulmonary inflammation, preventing exacerbation, minimizing treatment related adverse reactions, and extenuate the onset of progression of bronchiectasis. So, inhaled corticosteroids are used as used in the asthma. There is no specific regimen for ABPA. However, they should not be used in isolation because there is no evidence that there is benefits, that it prevents the progression of ABPA. Now, 50% of patients would relapse once the corticosteroids are reduced, and up to 45% will become corticosteroid dependent. Often, antifungal strategies are considered in such situations, and some studies have used corticosteroids and antifungal concomitantly for benefit. How does antifungal work? The antifungal agents reduce fungal burden, reduce antigenic stimulus, and reduce inflammation. Comparing itraconazole to placebo in the steroid-dependent ABPA, itraconazole reduced steroid dose by more than 50% and reduced Ig level by more than 25%. Some people also propose that itraconazole can be used at the outset along with steroid. My personal choice is whenever I see a advanced ABPA, I do use antifungal in the beginning for a period of 4 months and then continue with low doses of steroids along with inhaled bronchodilator and steroid. Other antifungals like voriconazole and posaconazole have been used, but there are no head-to-head trials. Itraconazole being inexpensive and we have large experience with it, my choice remains itraconazole. So, however, in cystic fibrosis population, which we hardly see in India, it was found that probably the posaconazole have been useful. Amphotericin B in a nebulization form have been used in some studies and which may be better tolerated, but I have no experience. Now, there are some patients who would not respond to the therapy or who would become steroid dependent, who are diabetics. You cannot give steroids for a long time. Is there a role of biologics in biologicals and ABPA as we have in asthma? And this is the review article, use of biological drugs for treatment of aspergillosis. So this is a summary. Use of biologic in ABPA is associated with significant clinical improvement and up to 90% uh, success rate is there. Omalizumab require more time to achieve improvement. There is a functional improvement and post-treatment FE1 rise were also noticed. So omalizumab showed a 45% reduction in the IgE and also 70% reduction in eosinophils. Now, mepolizumab, as we know that it is used for eosinophilic asthma, it reduced IgE by 67% and eosinophils by 90% from the baseline, and that after a treatment period ranging from 6 to 24 months. So reduction in annual exacerbation rate of 85% of patients and 98% of patients were able to either reduce the dose of systemic steroid or actually stop the steroid and use reduction in eosinophils in 99% of cases with a treatment for 3 months. Now, dupilumab has also been used and has shown a similar action. So, if you could summarize the use of biological, not too many studies are there, and there are no head-to-head trials. Omalizumab 133 patient, mepolizumab 62%, benralizumab 7%, dupilumab 26%, but there's 90% reduction in exacerbation, 85%, 90 and 85%. And most importantly, there is 66%, 98%, 95%, 90% reduction in steroid use. That is very important benefit. So, what is the summary? 32 studies revealed that biological treatment with omalizumab, mepolizumab, dupilumab, and benralizumab tended to favor patients with ABPA and asthma than those with cystic fibrosis. So, when to use biologics? Patients who are steroid dependent, patient has frequent excess of steroids and antifungal, patients having side effects of steroid or are unable to take steroids. Monoclonal antibodies control the disease by acting on different level of inflammatory cascade and therefore reducing the inflammation. The follow-up of these ABPA patients is by clinical symptoms with the lung function test. IgE is most important, should be done in every 2 to 3 months. HRCT should not be done very frequently. It should be need-based and not as a routine. Now, finally, I will discuss something which is very important, that is severe asthma with fungal sensitization. As I said, that we all inhale Aspergillus conidia every day. So, do every person who has fungal sensitization develop APA? The answer is no. Now, what is SAFS? That is patients that have severe asthma. They have raised eosinophil count. They have raised IgE. There is raised Aspergillus specific IgE and IgG, but normal CT scan. So, in a systemic review and meta-analysis of 20 observation studies that included more than 5,000 asthmatic demonstrates stated that the prevalence of Aspergillus sensitization and asthma was to the tune of 15 to 48% with the pooled prevalence of 28%. Similarly, another study conducted by Prasad et al. Prevalence of sensitization was 30%. So this is pretty common. The diagnosis of fungal sensitization was defined as an increase in specific Ig antibodies or presence of cutaneous hyperreactivity, which we are not doing routinely. Now, how do you treat such patients? You must not diagnose it as ABP. You have to use inhaled corticosteroid and bronchodilator as you treat for asthma. So the criteria are the total IgE of less than 1,000 units, positive immediate skin test reactivity, elevated specific IgE, the Aspergillus fumigacer, absence of serum precipitants by gel diffusion, elevated specific IgG to Aspergillus fumigacer, and no radiological evidence of bronchitis. The treatment is as you do it for asthma, but the recommendation is that these patients should be followed up every 2 to 5 years for development of ABPA. Now, why early diagnosis is important? Because ABPA is a major clinical importance because bronchiectasis can be prevented if the disorder is diagnosed and treated early. And notably, many patients with asthma will develop aspergillus sensitization. So, no patient who presents to us at this stage when there was a minimal bronchiectasis and there were random nodules there, and this unfortunate girl was put on ATT, and in 3 years' time, she landed in this situation where there was so much of fibrosis and she had breathlessness on exertion. So, this is the final part which is very important. If you have a patient with bronchial asthma, you do aspergillus specific IgE levels. If it is more than 0.35 units, then as I said, it has a sensitivity of 99 to 100%. Then you subject these patients to total IgE. If it is more than 500, do absolute eosinophil count. If it is more than 500 per cubic milliliter, and aspergillus specific IgG of more than 27 milligram per liter, then do a CT chest. If the CT chest is normal, you diagnose it as uh, bronchial asthma fungal sensitization. If CT chest shows high attenuation mucus, it is called ABPA ham. If the CT chest shows bronchiectasis, it is called ABPA bronchiectasis. However, if the CT chest is normal, then you call it ABPA sensitization. That is bronchial asthma with fungal sensitization. So these patients should be followed up every 2 to 5 years for the development of ABPA. So finally the take-home message is that ABPA is largely unrecognized, potentially treatable disease. All patients with asthma should be tested with IgE or Aspergillus specific IgE. In such cases, HRCT should be done for evaluation. If the Aspergillus specific IgE is raised and also concomitantly serum IgE and Aspergillus specific IgG is raised, the CT should be done. Judicious use of corticosteroids is warranted if the ABPA is diagnosed. Antifungal have a place in management, can be started at the outset. It's an individual choice. There's a role of biological which needs to be explored as there are no head-to-head trials. Inhaled medication should be used as in asthma. Finally, no patient should reach the stage of pulmonary fibrosis or advanced bronchiectasis or pulmonary or respiratory failure who presents to a physician with symptoms of asthma and as ABPA. So, ladies and gentlemen, this I just want to create an awareness about this disease, which is quite common. When we say 2.5% or more of asthmatics or 1.4 million patients in India are ABPA, it is our duty to diagnose them early and manage them to avoid morbidity and possible mortality. I would appreciate uh, uh, if you could write to me if you have any comments or questions at my email or WhatsApp me your question. I'll be most willing to answer. Thank you very much for your kind attention.